welcome to another episode of Vega Insights. I'm Luke Bideaux, President and CEO of Vega Imaging Informatics. And with us today is Jeremy Bikman. Jeremy is the president of Reaction Data and a former executive vice president of class. He's a avid mountain biker and an active thought leader in the field of medical imaging. So, Jeremy, it's great to have you today.
Well, thanks for having me on. Looking
Yeah.
forward to it. Should be good.
So we're going to have some fun today, and we're going to talk about politics. I'm not really a political
Yeah.
person, I wouldn't say myself, but politics as it refers to AI in healthcare and specifically in medical imaging, some of the different arguments that could be made for it, against it, and different considerations. We're here to have an open dialogue, and these discussions that we have, we're not representing the views of Vega or any particular company. They're all just kind of
Yeah, of
personal
course.
opinions. And of course, part of this is just presenting one side of the argument versus the other. But um, just encourage everyone to have an open mind when they're watching and really consider both sides of it and maybe learn some things that different perspectives they didn't have. So I'm pretty passionate about this topic because I do see AI as a major force in the future of medical imaging and healthcare in general, um, and it needs to be promoted and advocated properly. And my view is that government intervention can be helpful if it's done the right way in helping organizations adopt this safely and properly and incentivizing them to adopt it. And, on the other hand, um, anytime you start having a discussion about the government getting involved in something, there's going to be those that oppose it. And so, um, we're going to present some views on the other side of it too, right? So, um, I would propose that we start the conversation by sort of thinking back to the days of meaningful use when the government intervened and and started requiring providers to adopt electronic health records. And in those early days, there was certainly a lot of resistance about it. And from what I can recall, it was sort of an unprecedented move by the government when it came to healthcare technology. So there was a lot of uncertainty of what this was going to be like. Um, and for those of you that maybe weren't around in those days or don't have a recollection of it, this was a multi-phase program that the government put out, um, going back to about 2011, where meaningful
Yeah, high
use.
tech came out. The high tech came out, what, 2009, the High Tech Act? And then meaningful use was so kind of started, and then 2011 is when it
I think when it
officially,
finally, yeah, the meaningful use piece started becoming active, and
yeah.
there was phase one, which was an incentive-based program, no penalties in phase one, but the government was providing incentives for those provider organizations that were able to adopt, um, well, to meet the core objectives that they put out and choosing a subset of menu objectives and meeting all these requirements, and they got some incentive payments. But then in phases two and three, penalties started to get introduced, and the incentives started to go away, eventually leading us to where we are today, um, where there are no incentives, and it's all mostly penalty based. Um, MIPS and APM models. And so, um, this is not a new thing for the U.S. government to do some sort of program to incentivize or penalize organizations for not adopting certain technologies. And I don't think it's too far fetched to imagine a scenario in the future where some administration runs on um, the premise that they're going to help bring AI into healthcare and help reduce costs and help solve all the problems of healthcare. You think about the Obama administration, and one of their main things was they're going to bring EHRs into um, all of the healthcare systems in the U.S. within 5 years, and so um, that was certainly an intriguing agenda that many Americans got behind, and I could see something like that happening with AI. But um, before we get into things too deeply, I'm interested to get your thoughts, Jeremy, on just in general, your take on the government's involvement in healthcare as a whole. Is it best for them to take a minimal approach or be more involved? What's your general take on it?
Yeah, I guess I should preface it by saying I grew up in Canada.
Okay.
So, and I came to the US for, in part, because I wasn't a big fan of socialized healthcare, so to speak. Um, just because it takes a long time to get care. People say it's free, except the taxes are quite a bit higher in Canada than down here. So it's just a different way you're paying for it. There was a lot less access to like medical imaging scans. I mean, there was just a little, I could, I don't have it to share here, but there's a little infographic someone put out that there's actually more MRI scanners in the state of Pennsylvania than there is in all of Canada. So I just have a little bit different perspective. I got misdiagnosed a couple times. That's some of the most basic thing you could possibly imagine in Canada. And so I learned pretty quickly. I'm not sure this is for me. So I'm just a little skeptical about it. The government certainly, whether what the government should do or doesn't do or how they get involved, I'm not sure is super relevant in terms of from a historical perspective, just because it is. If you look at the sheer size of Medicare and Medicaid spending, I mean, it's trillions, right? A year. So it is like that, the cat's out of the bag, so to speak. The dog's running down the track. We're already there. So it's not you know, yeah, I don't think we're going to backtrack from that. Um, so speaking about meaningful use specifically, so when I was back at class, I joined class near the end of 2003. And one of the areas that we were doing research on, and so we would call, and that was part of what I did. I got thrown in the deep end, got half a day of training, and then they just said, "Hey, we're start calling CIOs, CFOs." Kind of funny story. First time I was calling a CMO, I thought it was a chief marketing officer. Remember how stupid I was? I got smacked down hard for a couple days. I'm like, all right, I need to really back this up. And there were hospitals and clinics, quite a few of them that were putting in back at the time. It was CDR, orders and charting. So it was clinical data repository, orders and charting. It had separate modules. So it was happening. So I think there's a big misconception that the vast majority of orgs didn't have anything digital in place. They weren't moving down the path. The government had to step in or it was actually never going to happen or it would take decades. And that's simply not true. Or organizations are putting it in. Siemens was there, Eclipsys was there, IDX was there, Epic was there. There was a lot already, and it wasn't just rev cycle. So we saw people putting and orgs putting it in. Um, it seemed like to me, as I was doing research and we met with government people, and again, we were talking to thousands of healthcare organizations at class every single month. So I saw from the inside. And then we would get updates from the different vendors that were going to Washington and they were helping to put together and write the laws, et cetera. So saw a lot, heard a lot. Um, my issue was it was rigid and it seemed to be artificially quickly and it didn't really account for interoperability. I mean, think about it, we're still talking about interoperability. Like, to me, Tefca and Fire and HL7 and the vendors that claim, oh, we integrate to this, it's kind of a joke because I've talked to, I'm talking to vendors all the time. And, I'm not going to mention the big EHR vendors, but some of the biggest EHR vendors, a hospital wants to put in this new digital health tool and the hospital wants it. Guess what? The hospital can't because the big vendor won't integrate to it or is putting up all these walls. So for me, what what I think should have been done is put a few guidelines in place to help accelerate adoption, not make it so rigid, but force the interoperability. Like if you wanted to really move healthcare forward from a technology and innovation perspective, have massive penalties on if you block data. If you're a EHR vendor or you're, PACS vendors are much better. I mean, let's be honest. Things that go on medical imaging, they just move faster and they play nicer with other people rather than the big enterprise ones. That's what I would have loved to have seen. And I support that big time, where there are real penalties if you block any data. It's the patient's data, it's the healthcare organization's data. The vendors, frankly, should have zero say in what happens there. So that's where I get a little, I guess, militant on it. So yeah, the government should come in and just swing a pretty broad hammer, so to speak, when it comes to knocking down the data latency that's going on everywhere.
Yeah. Well, interoperability was one of the main components of meaningful use. I mean, there's
Yeah,
so many
but
measures and
nothing
everything.
happened. It's
Well,
it's it's not good.
yeah, I definitely agree that, we did not end up achieving full interoperability at the end of the program.
Yeah, name another
And
industry. Could you imagine a big bank like Bank of America and they put in Oracle and Oracle goes, no, we're not. And then Bank of America wants to put in another system to integrate and Oracle goes, no, we're not going to do that. They would be out on their ear so fast. And I don't understand why hospitals put up with it in clinics. I just don't. I think it's almost like Stockholm syndrome, where it's just so backwards, and they've learned to put up with something no other industry will frankly put up with, which is I'm the customer. I want these two systems to work together, and you're either going to work together or you're out on your ear.
Mhm.
So that's what I hope organizations do is just stand up and say we're
I
done
find
with
it
it.
interesting that we have all these interoperability standards, HL7, Fire, Datacom thing,
Yeah, yeah, yeah,
but to actually achieve interoperability, such a hurdle in the United States is the
yeah.
legislation that we can't have a national patient identifier. We're
Isn't
trying
that
to
crazy? I
we're
agree.
trying to
That's nutty.
integrate 2 different health systems. They have to use different identifiers for the patients,
Yeah.
and then somehow there's this expectation that everything's just gonna flow around successfully, um, and it's hard.
How many Luke Bideaux exist? Like you exist in how many
Well, yeah,
different
that's maybe
spellings
not
and
the
all that
best
stuff.
example, but, there's so many challenges with trying to match on name, date of birth, gender, these
Uh-huh.
demographic data elements. So you've got the government that they themselves have mandated this, but they're also mandating or trying to mandate interoperability. And to me, if they could just remove that requirement that we can't have this national patient identifier, it would be the biggest thing to interoperability that's ever existed in the United
Yeah,
States.
I agree. Like, and I'm not going to get upset at legislation because typically legislation always goes too far one way. It just does, and that's okay because you're just trying, right? I think for the most part, people are trying, even in the government, politicians, and I don't like politicians. I just don't. I think anyone that seeks for power I'm going to be skeptical of them. But I think even they are trying in their own way to do the right thing. What I don't understand is when like HIPAA, where HIPAA goes too far and just say, hey, can we pull it back a little bit? We've learned a lot of stuff. Like we learned a lot of things. How do we reform it to make it right? And it's so hard to do. It's like the pushback is so difficult. It's like the gravity gets so strong, just trying to move it and go, oh, here's the good things about it. Let's slide this back a little bit. Or maybe go further. Maybe it didn't go far enough, right? That certainly could be the case. So um, that's kind of disheartening a little bit is to say, okay, great. like this national patient identifier. It's kind of crazy. Everybody should have a social security number, right? So you're like,
Mhm.
okay, well, there's nothing wrong with actually when it comes to for patients so that we solve this interoperability issue. And it frankly would help with fraud and waste too, right? I mean, there's so many things I would imagine it would help out with. So I agree with you.
Well, yeah, the national patient identifier thing, I mean, from what I've read about, the reasons why it's in place is to prevent fraud and for malicious attackers to so easily identify patients and be able to access, their billing information and all this stuff. But I just
That's already
I don't
happening though. I mean, let's be honest that
yeah,
that
it's already
yeah,
but
it's
yeah,
already happening. So
I don't see it as
yeah.
a particularly strong argument on why we should have it. And I just find that to be interesting. You don't hear too much about that discussion. You hear a
Yeah,
lot
that's
about
true.
interoperability challenges and
Yeah, we used to.
to
Remember
keep
like
better
10 years ago,
standards.
it was talked about a lot, and then you're right, it's just kind of evaporated.
Yeah. Yeah, so that's an interesting situation where you sort of have the government working against itself and then trying to put things forward that, would ease.
So you're working with a lot of radiology departments. That's what you guys do at Vega. I mean,
Yeah, I am,
are you
and
seeing the majority of radiology departments not putting AI in, pushing back against AI? Like that's I haven't seen that, but maybe you're dealing with a different group of people than I am because it seems
I
like people are
definitely yeah, I have. I mean, nobody nobody can get paid for the AI, so
that's
that's
true.
a big challenge.
Yeah.
It's not reimbursable for the most part. There's always exceptions, and there are some
Yeah,
exceptions
that's
there,
true.
but
Yeah.
since they can't get paid for it, unless they're seeing some sort of monumental efficiency gain or something, it's hard to justify the costs of it. And this is a big one on why I think the government does need to get involved. Um, and it seems like we're slowly headed down this path where, at least at the accreditation side of things, we're starting to see like the ACR's Arch AI program develop, where they're starting to set some guidelines on um, the safe and effective use of AI in medical imaging. Um, and I could see things happening down the road where, um, just like with other types of accreditations. Now, the RTAI program is not an accreditation program, it's a
Yeah.
voluntary attestation type of thing, but in the future, it could evolve to that. And, um, the current landscape in the US with accreditation is there's a lot of tie-ins to payer um, payments. So, since there's really no accreditation program for AI, you can't prove that you're using it safely or effectively or anything. um, the insurance payers, find it more challenging to reimburse for those things. Um, but yeah, I think finding ways to compensate the providers for the use of AI properly is the big challenge. But the government, they don't focus initiatives at one specialty at a time typically. Like I can remember when the meaningful use phase one rule came out, I was so surprised to find that there was nothing about medical imaging in
Yeah. Yep.
any of that, requirements. And so the laws, or the program included medical imaging, like outpatient practices or teleradiology practices could participate in the program, but yet it wasn't really designed for them. And I definitely could foresee the same mistakes happening with any kind of program or legislation that comes out regarding AI and not tailoring it to all the specialties that have different types of needs. Um, In phase 2 of meaningful use, they started to introduce a little bit about imaging, like requiring imaging results to be in the EHR, but it was minimal, and there were many measures that really were not applicable for those medical imaging practices, and therefore there was a lot of kind of gaming the system where they would attest that they're doing these things, but in reality, they're just putting in default values like, yes, we're capturing the fact that we have no known medications for this patient. And yes, we're capturing um, a race and ethnicity of the default value of unknown or patient declined or something. So they do a lot of this um, sort of reworking their workflow to fit the mold of the program rather than the program tailoring the requirements to those specialties that have those different needs. So I worry about that with any sort of legislation that may happen with AI. How is it going to pertain to medical imaging? And this is really where we need organizations like the ACR and RSNA and others to step up and collaborate with the government in these programs that could come out in the future. And this is why I just think it's so important for everyone to be involved with these emerging standards and guidelines that are coming out. If you don't agree with them, be part of it and let's make it better
Mhm.
together because those are the types of things that could eventually become suggested to lawmakers and become, part of some sort of programs that are, going to have effects on reimbursements and things or just straight out laws that everyone needs to follow. So, I think it's everybody's job to be on top of how these new guidelines and standards pertain to their specialty and try to advocate for that.
Yeah. Yeah, I hope so, and I think so. I mean, it was good to see, even though it's not directly, related, to setting the reimbursement, like Dr. Rick Abrams is the new Director of Digital Health of Excellence for the FDA, so all AI and digital health falls under his purview now for the FDA, and he's a radiologist by background, so,
Yes.
great guy, which is fantastic. So you talk about the reimbursement, which I think is important for a lot of aspects, to get adoption. I mean, there's certain things like using LLMs to review, um, studies in radiology to get that actually will identify and then flag different patients to come back in. So there is a way to actually pay for it with that kind of thing. And then if you look at other things like, so you had adoption of speech recognition in radiology pretty much before anywhere else. There was no reimbursement tied to it. They're already spending money for dictation. It just made sense. There are certain times when the AI just makes sense, because it is demonstrably better and there's an ROI that you don't need to attach a specific reimbursement. It's making the radiologists, more efficient. I just saw this. I just posted something this morning that like 50% of different 8 different subspecialty fellowships it didn't even reach the 50% mark, and one of it was emergency radiologists. So you're like, I don't even know if they shouldn't wait. Like if there's some AI they can put in to make their radiologists a lot more efficient because they're becoming more and more understaffed. Um, I think you have to do it. But yes, there's certainly going to be a lot of cases where uh, for AI to really take hold in certain areas, especially clinical cases, you're going to need some regulation around it, right? And reimbursement directly tied to it. So that makes sense.
You mentioned the FDA, and I think many AI developers would say that the lengths they have to go to get their FDA approval and the
Oh,
costs they have to
yeah,
overcome
yeah,
really inhibit
yep,
the development. And
100%.
so that could be, an argument where maybe the government is going too far from their perspective. On the other hand, um, maybe from the provider patient perspective. Nobody wants, let's say there's a corporation out there that decides they're going to just let the AI read chest x rays because it's cheaper than paying the radiologist to have them
Yeah,
read the chest
and
X-rays,
they
and
ignorantly think it's easy, right? Like, "Oh, it's too easy," right? Yeah, so
yeah,
AI could
well,
just
but,
do
that's why
all of this.
there's
Yeah.
checks and balances here, right?
Yeah, for
So,
sure.
there certainly are corporations out there, I'm not gonna name any names, but that would do things that are maybe not the best for patient care, but can help their bottom line, and that's where
Yeah.
I think the government really needs to have
Oh, well, for
oversight there,
sure,
and
right?
yeah,
But the FDA go fast. You remember when digital mammo came out? Who's the first digital mammo? Was it Kodak? Did they get the first? They had the first approved.
I couldn't say, but,
And I remember being at RSNA and then the conversations even at ECR where they couldn't understand like all these other vendors like Fuji and GE and all these other ones, like they had it all filed. It did the same thing I think that Kodak did or others. Like it was just there, and there was no reason to wait. There was literally no reason. It passed everything, but it just sat. So it sat
mhm,
for a year or two, and so the original vendor gets this full monopoly for 2 3 years, while all the other companies approved everything. They have nothing else to do, but they just sit.
yeah,
6 months later, a year later. So I agree. There shouldn't be a get rid of the process at all. But I think anyone that thinks it's a really efficient, well-run process, I'm not sure that that's the case. So you can,
yeah,
because they could use AI. That's where they should be doing it, is within the FDA to say, hey, you have a lot of processes here that are wildly manual. Like I bet it'd probably freak us out to go, you guys are doing everything on Excel still or Word docs. And you're like, hang on a second. What are you doing? So I think they could still stick to their process, but look at all these, huge amounts of inefficiency and say, here's all the steps, but instead of it being this long, we can do it. You're still doing all the steps. It's just half as long. So I'm not advocating for any steps removed, but I'm pretty sure they can make it more efficient.
mhm. So, I mean,
And
it's an
would you want
interesting,
an organization regulating AI that doesn't use it themselves?
um well, that's a good point,
It's like there's an old
yeah.
saying, never trust a bald barber, right?
Right.
So anyway, it's just a little funny
There's
saying.
this yeah, there's this sense that, the government's out of touch with what's happening in the real world, and so
But if
I
they hire
hear
people
that.
like Dr. Abramson, that's a good sign. You get people that, because he's worked. Yeah, obviously he's a clinician. He's been a professor, a practicing clinician, but he's also worked in industry. He's worked for AI companies and other companies, and so he gets his hands dirty. So he's not like an ivory tower, just sit back and going
Mhm.
and being disconnected from patients, disconnected from clinicians, disconnected from industry. He's got his hands dirty and got the bruises and kind of the scars. And I think those are so I'm encouraged by that kind of thing.
Yeah, it's been interesting here to get your perspective. You're coming from a place where government-run healthcare, uh, was in place, and from what I'm hearing, your attitude towards the government in healthcare is that the government should not run healthcare like Canada or other countries, UK. Instead, it should implement laws and rules that health healthcare organizations need to follow, but not necessarily completely run it. Um, let's dive a little bit deeper into the philosophical stances on the government's involvement in this. So,
Sure.
um, I consider myself sort of a conservative person politically, and I like the free market system we have in the U.S. And um, traditionally, I would prefer the government to stay out of most things because the things that they tend to get involved with, I don't always agree with how how they run those programs and everything. Um, except when it comes to healthcare, I actually have found myself more inclined to promote government involvement in healthcare. Um, and I've thought to myself, well, why is that? Why is that different for healthcare compared to other things. And I think kind of what it comes down to is I see healthcare as something that all Americans should get, equally. And it's odd the way it is now because currently really no American is left behind when it comes to healthcare. Doesn't matter your income status. There are programs that you can get on to get healthcare. But yet it seems odd where, the middle class doesn't get subsidized really for their healthcare, and they pay these exorbitant rates for insurance,
Mhm.
and they get, basically the same type of care that somebody that's not paying anything for their health insurance. And it's a strange program that we have to me. And then you have these middle layers. You have these insurance companies making billions of dollars. And it's like, why do we need
Mhm.
that? You've got
Mhm.
corporations owning practices and operating, healthcare practices around the country. And those corporations are making huge margins. Um, and do we really need that? And so I feel like the system we have right now is not perfect, and we
Sure.
need to do something different. Um, so I would advocate for more government involvement to cut the fat that I just mentioned there, where all the money's going that we don't need it to be going to, and reduce the overall costs, and keep the money in the hands of the people that should have it, like the providers and you know the patients, and so the government should be working towards that. And I definitely see the healthcare of the future, and especially in medical imaging, being totally different than what we have today, and primarily due to AI. I think government should really be involved in this and should be driving this because it could really do great things. It can significantly bring costs down. It can improve access to healthcare. Like you look at third world countries that don't have enough doctors to do anything, and now with AI, they can get some level of opinions on things that were way better than what they had before through the use of AI. And I think even in America, there's opportunities for better access to care through AI than without. But there's the other side of the coin that if the government tries to do this, they will completely screw it up, like with meaningful use. And I think that's sort of where you were coming from with meaningful use. It was not a successful program, and the innovation and adoption would have happened anyway without their involvement.
Well,
Um,
on the meaningful use side, so I just remember some of the big claims that were made. And unfortunately, a lot of this stuff gets memory hold, where its costs eventually will come down. That was the one thing. Well, costs have not come down. They're very expensive. So if you look at hospital bottom lines and clinic bottom lines, are they getting better or worse? They're not getting better. Um, Patient outcomes, have they gotten better or worse? You can't tie improved patient outcomes. So they just spent a lot of money to digitize things. So it's not like it was bad. It was the claims that were made just weren't realized. And when it comes to government, like I don't know if the government getting involved brings down costs. It typically raises costs. If you look at like education, like student loan debts, like out of control spending at university levels, is because which is kind of sad. Like you allow an 18-year-old student to enter in and get whatever loans they want to go into get a degree in English with a minor in music. Like, okay, should that guy be allowed to go $100,000 in debt for a bachelor's degree in English and I have and then they can't discharge it in bankruptcy court. So typically when the government gets involved in something in a big way, over time the costs actually go up. But I agree with you though about so many different issues. The middleman problem in healthcare is a big problem. Like, what's the purpose for PBMs anymore and RBMs in these days and age? The middle layer extracts so many costs. Um, and then you look at kind of the bureaucratic aspect, and then you go into a hospital. How many people who work for a hospital aren't clinicians or directly supporting clinicians? Like, how many different there's administrators and that kind of thing. And then you look at some of the nonprofit hospital organizations, they're swimming in money and they have all these different tax advantages. So there's a lot of stuff I would look at first before coming in and saying the government just needs to take it and we need to run right into a single payer program. Because if you do, it's just true. If you do a single payer system, there's rationing of care.
Mhm.
Look at every country out there that's done it. Um, so I would, and same thing with like health insurance. Like it should be more like car insurance. You should be able to, any insurer should be able to compete in every single state. There shouldn't be regions of it. There should be zero protections. There should be no protections for health insurance companies at all. And a lot of the stuff that they extract out is frankly ridiculous. And there should be no government protections for health insurance companies at all. I mean, you're talking about it. And then frankly, allowing where I would say the government should step in as well is allowing these health insurance companies to also become some of the largest provider organizations in the country. Well, that's a problem as well. So how can you have like United Health Group, for example, that owns more physicians and nurses than HCA or anybody else? That's not great. So there are certain things where I think the government can step in and do right away. And if they would, if I could trust them that they would actually slash the waste and say, hey, there's just a lot of friction here that just doesn't make sense anymore. We don't need this. I would two huge thumbs up because the money should follow the patient. The patient should be more in control of what they choose. And it could be that, even having employers be the thing that actually where the insurance comes from, it doesn't make as much sense. So I'm definitely open for a lot of different um, avenues because I agree. The money should stay with the provider, but it should follow the patient.
Well, let's tie it all together here with the bottom line about AI and healthcare, medical
But yeah, that's
imaging.
right. That was the purpose.
Yeah, I mean, I guess the question is, would we be better off without the government expanding their reach into into it? Do you think that the innovation and the adoption will drive itself and um, will wind up in a better place in the future without the government involvement, or will it require some intervention in new programs to move it along? And my stance on it is that yes, we need to enact some programs that are going to move this along because I do see AI as the answer to a lot of the problems that we face with the inefficiencies in healthcare and the shortage of providers and things like that. And
Yeah.
also just the advancements in AI are making such a strong case for the use of it that it's just better. And it might not be there right now in a lot of ways, but you know, 5, 10, 20 years from now, it's hard to predict how good it's going to be.
Mhm.
And there's really not a great pathway for that AI to really make the type of impact that I think it could make as it stands right now. Um, so I think something like the meaningful use program, or, but obviously much different than that with lessons learned from their previous attempt. Um, or just, new policies that incentivize the use of AI and penalize those that are not utilizing it where it's proven to be effective, I think would make such a a positive impact on things. Providers might not like it at first, just like they didn't like EHRs being pushed on them. But who's going to go back to paper medical records now?
No,
Even though
yeah,
there was
yeah.
resistance at the beginning, and I kind of see the same thing with AI.
So I like your idea about reimbursement. So I would rather see if there was going to be government involvement, besides from the safety perspective, right? You still have to have the FDA involved, especially anything clinical. If it's something as simple as, hey, it's doing automated messaging to patients to remind them at appointments, I don't think you need a lot of regulation around that, because that's like saying, you know, how is a doctor allowed to text a patient as long as they don't put PHI into it? We're not going to say what a doctor can or can't say in a text, right? Like, no doctor would want to practice medicine if that's the case. With really specific clinical cases, certainly FDA's got to be involved. There's going to be some privacy and regulatory things that need to be put in place, or even just extend it to it. It's already there. You just extend it to those algorithms. So tying reimbursement's fine. Like if you just say, hey, if you're doing FFR, it does this, you're going to get paid X. Like that's fine. That's the government saying there's a value and it'll pay for it. But that's not meaningful use. That's very different than meaningful use. Meaningful use is you have to put in these types of algorithms and you don't have a choice, because meaningful use had a carrot and a big stick. I don't like a stick. Like if it's a good technology that makes sense and you can get reimbursed for it, why in the world is there a stick? So that part I totally disagree with. I look at PACS as well. There are companies like New Lantern and others that might just fully replace a PACS. Should they get paid extra money if they just replace existing systems, or kind of emerge to take over that if there aren't reimbursements? So you're asking really good questions. I'm pretty good at the philosophy side, but I'm not that great at the implementation. It's easy, right? I could just kind of ivory tower it from on high, sit on my rock, going or whatever. But it's easier. So, your idea about having reimbursements tied to thing that would cover it. I don't think you would need to do any sort of actual global comprehensive legislation that's like meaningful use, because if there's reimbursements tied to it for that kind of thing, then why wouldn't someone put it in? It's better technology and you get paid for using it. So great.
Right. Yeah. Well, it starts with opening the conversations, right?
Yeah, of course.
And people listening, and maybe they have a stance going into the conversation, and maybe that opinions changed coming out of it. Um, but as you stated, it's so much easier to talk about it. It's much harder to actually implement it, and that's why it's so important to me that people take action and get involved in all these different initiatives to set the guidelines and the standards which can form the future of legislation in these areas. So, um, just want to encourage everyone to try to get involved and stay on top of things, and just give it your best effort to improve the way our future state of healthcare is. Want to thank Jeremy for joining us today, and we'll go ahead and conclude the sessions. Have a great day, everyone, and till next time.
Thank you, Luke. This was great.